Thank you for joining me for this e-learning module. Today we're going to talk about tip stents and how we evaluate them for dysfunction using Doppler ultrasound. At the end of this module, I hope you will understand the importance of angle correction and how we measure velocities on Doppler ultrasound. I hope you will understand the key components to a Doppler ultrasound evaluation of TIPS stents and be able to list the different measurements we need and know how to properly attain those measurements. And finally, I want you to be confident with assessing angle-corrected velocities for accuracy so that we only report and record good measurements. We're going to start by reviewing the concept of Doppler shift and how we measure velocity with ultrasound. We're then going to talk about how abnormal tips placement can lead to dysfunction and how the distal tips is often the site of that dysfunction. We're going to then review how we screen for tips dysfunction with ultrasound, and then we're going to look at a number of cases and we're going to QA those cases for accurate or inaccurate measurements. Alright, so Doppler ultrasound. With ultrasound, we're able to measure the velocity of moving objects within the field of view. We do this based on the concept of a Doppler shift. So when the ultrasound beam is directed toward a moving object, that moving object hits the ultrasound beam and compresses the frequency, sending a different frequency back to the ultrasound probe than was sent from the probe. The shift in that frequency is detected by the probe and used to calculate the velocity of the moving object. Objects that move away from the probe, when they encounter an ultrasound beam, they stretch that frequency or make the frequency lower, and again the Doppler ultrasound detects that shift in frequency and is able to calculate the velocity of the moving objects. The change in the frequency is proportional to the velocity of the moving object, so the greater the change, the greater the velocity. In this case, we see that the frequency of the blue sound wave is half the frequency of the red sound wave. So that difference in frequency is the shift that the probe uses to calculate velocity. To accurately calculate velocity, we also have to take into account the angle of inclination. The shift that is encountered due to the moving object only accounts for a portion of the actual velocity of the object, in this case red blood cells. To calculate the true velocity of those objects, we have to use the angle to correct the velocity detected by the probe to account for the actual velocity of the moving object. Our measured velocity is this white vector, but the velocity we want to know is the yellow vector. We can calculate that yellow vector by separating out the different components of the white vector. So the white vector is actually comprised of both the y and x components of velocity, and we want to get rid of the y component and only account for the x component. In most cases, the velocity that we are detecting is going to be lower than the actual velocity of the object. So, to calculate the actual velocity of the moving red blood cells, we divide by the cosine of the angle. Now, the cosine of 0 is 1. So if you were able to take an ultrasound image of something moving directly at the probe, you would not need to angle correct that measurement. If you attempt to take a measurement of something moving at 90 degrees from the probe or perfectly perpendicular to the probe, the cosine of 90 is 0, and therefore we will not be able to accurately measure velocities of objects moving at 90 degrees with respect to the probe. In between 0 and 90 degrees, we have a number of fractions that are equivalent to the cosine of those different angles. So we divide our velocity detected by the probe by these fractions that account for our angle of inclination, and that gives us the velocity within whatever object or structure we are interrogating. Here's a different way of looking at that. So this graph shows velocity on the y-axis and our angle of inclination on the x-axis. If we assume the unangle corrected velocity, or the raw velocity detected by the probe, is 100 centimeters per second, and our true angle of inclination is 60 degrees, we see that our calculated or angle corrected velocity is 200 centimeters per second. And that's because the cosine of 60 is 0.5. So we take 100, divide it by 0.5, and we get 200. Now, if we don't angle correct properly, in other words, if we under-angle correct by 40 degrees, so our real angle of inclination is 60 degrees, but instead we angle correct on our ultrasound machine to 40 degrees, we see that we underestimate our velocity. So the cosine of 40, when you divide that into 100, gives you 130. And so our raw velocity is 100. The velocity we should be getting is 200 if we properly angle correct to our true angle of inclination that's 60 degrees. But here we under-angle corrected and we underestimated our velocity. Now, if we over-angle correct, so again, our real angle of inclination is 60, but on the machine we angle correct to 80 degrees, we see that we dramatically overestimate our velocity, and in this case, the velocity of 100 divided by the cosine of 80 is 588 centimeters per second. There's not really a good mathematical reason why we tell people to not obtain measurements above 60 degrees. The main reason that we tell people to stay below 60 degrees is that small errors in angle correction result in large angles of velocity. So if you're at 65 degrees angle of inclination and you are just off by 5 degrees, that's going to affect the calculated velocity a lot more than if you are at 40 degrees and you make a small error in your angle correction. Because you can see the slope of this line is a lot less down here between 30 and 60. So making small errors in your angle doesn't impact the velocity as much as making small errors in angle on this part of the curve where the slope is much greater. So, key points to remember with angle correction. Our preferred range is 30 degrees to 60 degrees. Traditionally, it was 45 degrees to 60 degrees, and I'm fine if you stick within 45 degrees and 60 degrees. If you can't get the angle to be between 30 and 60 degrees, work on the technique a little bit. Maybe heel in with the probe, toe in with the probe to change the angle of the probe with respect to the structure you're interrogating. If you can't get the angle to be between 30 and 60 by just changing your probe angle, you may need to move to a different sonographic window, whether it's subxiphoid, subcostal, intercostal, so that you can approach the structure from a different orientation and get your angle to be between 30 and 60. Now, if you still can't get your angle between 30 and 60, I still want you to accurately correct the velocity. So if the angle is 25 and that's your angle of inclination, correct it to 25. If it's 65 or 75, correct it to 60 or 75. Now, if you overcorrect, meaning your angle of inclination is 45 and you correct it to 60, remember, you are overestimating the velocity. If you undercorrect, meaning your angle of inclination is really 60, but you put an angle correction of 45, you are going to underestimate your velocity. And the key thing to remember, a properly corrected angle at 70 or at 20 is better than any improperly corrected angle. So if you can perfectly angle correct at 70 degrees, you're still going to get an accurate measurement. It's just small errors have a big impact. And at 20 degrees, small errors won't necessarily have a big impact, but it can sometimes be hard to get a nice clean signal when you are at such an acute angle. Now let's talk about TIPS stent placement and how that placement affects where problems occur and where we need to focus our ultrasound studies within the TIPS stent. So, ideal placement. We're going to start in the right portal vein. We're going to put the TIPS stent through the liver parenchyma. Notice that the TIPS stent has this covered portion and then this uncovered bare metal portion. So it goes from the right portal vein typically into the right hepatic vein. Okay? Now you can go from the right portal vein into the middle hepatic vein, or you can go from the left portal vein to the left hepatic vein, but the safest approach is from that right hepatic vein and right portal vein, and so that's the typical location of our TIPS stents. Notice that the TIPS stent should extend, this bare metal portion should extend into the intrahepatic IVC. And even more importantly, the covered portion of the stent needs to extend into the vessel. If part of this TIPS stent does not extend all the way into the vessel and is surrounded by liver parenchyma, then you can get an inflammatory reaction with subsequent fibrosis and stenosis, or what is sometimes called pseudo-intimal hyperplasia, and that results in abnormal flow in your TIPS stent. And it often occurs over time. Many times these days we start to see this within the first 6 months of TIPS placement. Now, here's an example of an MRI that I have done in a reformatted plane so that we can see the entirety of the stent. The stent is going to go from the right portal vein towards the inferior vena cava. Note that the distal part of this TIPS stent is actually within the liver parenchyma. It does not extend out into the inferior vena cava, and this person developed an inflammatory reaction with fibrosis that resulted in stenosis around the distal end of the TIPS stent. So let's talk a little bit about detecting TIPS dysfunction. A lot of people believe that clinical signs are the best indicators for whether or not a TIPS is functioning normally. So TIPS are placed for 3 primary reasons: people who have refractory ascites, people who develop massive GI bleeding or variceal GI bleeding, or people who have pleural effusions that recur and cause difficulties with breathing. After a person has had a TIPS placed, if those symptoms resolve and then reoccur, then there's a high likelihood that there's dysfunction of that TIPS, commonly stenosis of the TIPS. The problem with relying on clinical signs and symptoms is that we may not detect the stenosis until something serious happens, like a massive GI bleed. And so we would like to be able to have a way to screen for dysfunction before symptoms recur. Also, we know that once a stenosis becomes so severe that symptoms recur, it can be harder to revise the TIPS stent. So, our most common modality to evaluate TIPS for dysfunction is ultrasound, and we use Doppler ultrasound to screen for abnormal TIPS. There's a number of different values that we use. Okay, there's not very good agreement within the radiology community on which values are the best. I would recommend using a holistic approach or a multifactorial approach where we look at all of these different abnormalities. If we see one or more abnormality, we can question dysfunction. If we see multiple abnormalities, then we may directly recommend an invasive interrogation with venogram of our TIPS stent. So, on this screen you can see the basic commonly accepted values. So if the main portal vein velocity drops below 30 centimeters per second, that may mean that blood flow is not going through the portal venous system well, and there's a stenosis in the tips. If velocity within the tip stent is greater than 190 centimeters per second, that may indicate that there's a stenosis, and that stenosis is resulting in a high velocity jet of blood right at the stenosis or just distal to the stenosis that we can detect with ultrasound. If we see velocities within the stent that have dropped below 90 centimeters per second, and some people would argue you should use 60 centimeters per second, well then that means that blood is not flowing through the stent as it should, and there's probably a stenosis distal to that area of slow flow. A final factor that we can look for is a change from the prior study. So say someone had a prior study in which blood flow within the stent was from 150 to 180 centimeters per second. They come back in for another study, and we now see blood flow within the stent ranging between 90 centimeters per second and 120 centimeters per second. Now that 90 to 120 still fits within our criteria for absolute velocities, but because there's been a change of greater than 40 centimeters per second since the prior study, that may indicate that there's a change in the stent and stenosis is developing. Another thing we can look for is focal aliasing. Focal aliasing indicates either very high velocity flow or turbulent flow, both of which can indicate stenosis. And then finally, we can look at the flow within the other portal branches. Typically, with a tip stent in place, the flow within the portal branches should be retrograde. When stenosis develops, that flow will revert back to antegrade flow in certain individuals. Now, as we talked about before, stenosis most commonly develops in the distal part of the tips. Okay, so we see in this case, the distal tips, we're starting to get some impingement on the lumen of the stent. We can also have stenosis of this outflow vein. Okay, so if that distal tips is not out in the intrahepatic IVC, that metal portion of the tips can sometimes irritate the outflow vein or the hepatic vein, and that irritation results in inflammation and stenosis at the distal tips. And that can restrict flow through the stent. Now, when stenosis has developed, we will see that the velocities proximal to the stenosis are going to be decreased. And these areas are indicated by the blue stars. Now, at the stenosis and immediately distal to the stenosis, we will see velocities greatly increased. And that's because the same volume of blood that's flowing through the wide open portion of the stent now has to all flow at the same time through this narrowed portion of the stent, and that results in a high velocity jet. Also remember, flow is going to take the path of least resistance. So in a person with portal hypertension and high resistance through the liver, when you place a tip stent, that relieves that resistance, and the flow within the portal venous system all should revert through the tip stent. When stenosis develops, the resistance within the tip stent is going to increase, and at some point the resistance within the tip's stent may be greater than the resistance within the liver, and if that occurs, flow within the portal branches will reverse and be antegrade. Okay? So antegrade flow in the presence of a tips within distal portal branches is actually an atypical or abnormal finding, which is somewhat counterintuitive. Now, evaluating a tips stent with ultrasound. We're going to go through each component, talk about some of the pitfalls. The first thing we're going to evaluate are the portal veins. So, what are we trying to achieve when we're measuring velocities in the portal veins? What we want is a representative velocity prior to the tip stent. After placement of a tips, the velocities within the portal veins are going to increase. Typically, those velocities are greater than 40 centimeters per second. When stenosis occurs in the tip stent, the velocities will lower or decrease within the portal vein because blood cannot flow through the portal vein quite as well. So the velocities will decrease, and we have set 30 centimeters per second as a threshold for abnormal flow. So if the flow in the main portal vein drops below 30 centimeters per second, we consider that abnormal, and we may question dysfunction. Here's an example of a spectral wave Doppler evaluation of the main portal vein. We can see that the portal vein has nice antegrade flow. We can see the indicator of our angle correction properly aligned with the flow of blood, and we see that the value or the velocity within the portal vein is calculated to be 10.7 centimeters per second. We then move distal to that main portal vein into the area of the tips, and we can see that the tips is occluded. So there is no color flow through the tips, and the lumen of the tips appears hyperechoic, which is abnormal, and in this person indicates occlusion. Again, portal vein flow less than 30 centimeters per second was detected and raised our suspicion of abnormality within the tips. The next thing we want to look at are the branches of the portal vein to determine the flow within those branches. Again, retrograde flow is typical because all of the portal flow is now directed through that tip stent because it's a lower resistance system. Antegrade flow is abnormal and may occur if stenosis within the tips has resulted in resistance that is greater than the resistance through the liver. Now, sometimes you can have antegrade flow without tips dysfunction if there are large, naturally occurring shunts, like a recanalized umbilical vein or cardiac vein. Here is an example of a person with a tips. We have color flow on the tips. We see the main portal vein here. We see the tips here, and we see a branch of the right portal vein with antegrade flow. This makes us suspicious that this tips is not properly functioning because this flow should be coming back through the tips, not going out into the liver. We see this apparent aliasing, which also raises our concern for tips dysfunction, but as we'll talk about in a few minutes, the color scale here is probably too narrow, and the aliasing may not be true aliasing. In this person, we do see on CT improper placement of the tips, where the distal tips is within the parenchyma of the liver, and a stenosis has developed from the liver parenchyma fibrosing in around the distal tips. So when we think about color Doppler of the tips, one of the first things I want you to think about is color scale. Okay? So after we've looked at the portal vein, we're now moving on to evaluating the tip stent itself, and we're going to first do that with color Doppler. Now, velocities within your stent are often going to be greater than 90 and less than 190 centimeters per second. So you want the range on your scale to be similar to your expected velocities. So plus or minus 75, plus or minus 100 is going to be a color scale that will let you see whether there is aliasing within that tip stent. Now, if you don't detect color flow with a high scale, then you want to lower your scale, because lowering your scale is going to help you detect low flow and be confident there's no flow when you've brought your scale very far down or even moved over to power Doppler. But when you're looking for high flow areas or aliasing, you need to have your color scale cranked up into a high range. And when you're looking for aliasing or high flow, you really need to focus on that distal tips and in the IVC, because that's where the stenosis often occurs, and the high flow occurs at or just past the stenosis. Alright, so this is a case where we see apparent aliasing within our tip stent. Okay? When we look at our color scale, we see that it's plus or minus 25. So that is a range of approximately 50. And when we come over to our spectral wave evaluation of the same tips, in the location that we were evaluating it with color, we see the velocities to be 162 centimeters per second. So these velocities are high enough that they are going to cause artifactual aliasing due to the narrow range of our color scale. So because we do detect flow at this scale, we want to keep increasing our scale to be in a range that accommodates our high velocities and helps us detect areas of aliasing. This is another example where someone is interrogating the distal portion of a tip stent. Okay? We see what looks like narrowing, aliasing, turbulent flow. This is concerning for stenosis. Again, the distal tips is where we often see this stenosis occur. When we look at our color scale, it's a little higher than on the last case, so our range is close to 80. But when we go back in this same patient and we raise our color scale up to plus or minus 77, so now our range more around 150, we see that there's nice uniform blood flow through that distal tips, and there is nothing to be worried about. So, when we're getting our spectral wave velocities within our tips, we want to keep a few general goals in mind. We are trying to find the highest velocity within the tip stent and the lowest velocity in the tip stent. We try to improve our detection of the highest velocities and the lowest velocities by segmenting the stent into 3 different parts: the proximal portion, the mid portion, and the distal portion. And then we interrogate each of those 3 segments. Again, what we really want to do is just find the highest and the lowest velocity. So I want you to look in each segment, take a few samples, maybe look at your color flow for areas that may be low in velocity or high in velocity, sample those areas, and then report the highest and lowest velocity, or record the highest and lowest velocity in each segment. Because the highest and lowest values overall are what we are going to judge dysfunction or normal function from. So sample throughout your tips and give us the highest and lowest value in each segment, which will hopefully capture the highest and lowest value in the tip stent overall. Now, the end of the tips, the distal tips, it's the hardest part to see. Often the penetration into the liver when it's that deep is difficult. The angles can be tough there where the tip stent starts to go into the hepatic vein or into the IVC, but it is the most important part to image. We need good color flow images there with appropriate color scale, and we need a nice velocity right at the distal part of the tips, or even distal to the tips within the hepatic vein or the IVC. And that's going to make us most sensitive to tip stenosis or dysfunction. Okay, here's an example where someone is interrogating the distal tips. And I wouldn't say that this isn't within the distal part of the tip stent, but it's pretty close to the junction of the mid portion of the tips and the distal tips, as opposed to that terminus of the tips, the very end of the tips. Okay? In this same patient, we see that they were having probably trouble getting a good spectral wave and good grayscale or color visualization of that distal tips. So we see here some aliasing in the region of the distal tips where it joins with the IVC. Okay? Now, here they've tried to take a spectral wave velocity that's angle corrected. I want you to look at this angle and the velocity we're getting, and we will blow this up a little bit, okay? And let's see, where do we think the blood is flowing, right? So here's the IVC, right? Here's some hepatic vein. This is probably part of the tips coming in. So we can see that the indicator that shows how we've angle corrected for the blood flow in this particular vessel is probably inaccurate and should really be turned into almost a different direction. Okay, and so that's what we're going to start to look at next. How do we properly angle correct? So everybody gets very fixated on having an angle correction between 45 degrees and 60 degrees. And that's fine. That is where you're probably going to get your best measurements. I would argue that you can extend that out to 30 degrees to 60 degrees, and there have been some recent papers that have shown with modern ultrasound machines and really precise angle correction, you can really expand this range as long as you're very confident that your angle correction truly reflects the direction of blood flow. Now, if your angle is not within 30 to 60 degrees, again, change your probe angle, toe in, heel in, change your sonographic window, approach the structure from a different location, okay? But if you're not within 30 to 60 degrees, that is okay. Angle correct to whatever the blood flow is as best you can. So, let's look at this first case. We see the main portal vein. We see the color flow indicating the direction of flow. We have a little spectral gate here, and we have an indicator showing how we have angle corrected. Okay. So pause the video, take a look at this, and decide if this is angle corrected properly. So this is not proper angle correction. I would argue that the flow is moving more like that yellow arrow is oriented than like our angle correction indicator is oriented. So, if our angle is really more in the 0 to 20 degree range, and we have angle corrected to 50 degrees, how does our angle correction affect our calculated velocity? Is it an overestimate or an underestimate of the true velocity within the portal vein? So it is an overestimate. The blood flow within this portal vein is likely less than 70 centimeters per second. Here's another case that's a little more tricky, and we'll go into why. So pause the video and decide whether or not you think this is properly angle corrected. So this is not properly angle corrected, and I'll explain why. The flow of blood that we are interested in angle correcting for is the blood flowing through our gate, not the general direction of blood flow within the vessel in our field of view. And in this case, our small gate is located in a part of the portal vein where the blood flow is more aligned with our arrow than is aligned with our angle correction indicator. Now, I will agree that the blood flow within the portal vein just distal to our gate is flowing in the direction of our angle correction indicator. In fact, the little junction between our indicator and this yellow arrow, the blood is probably flowing in the way that was angle corrected for. So how does this angle correction affect our measured or calculated velocity? Again, it is an overestimate. So our flow of blood is more in the 20 to 30 degree range. We have corrected to 50 degrees. We are overestimating the flow within the portal vein to be 70 when it's really much lower. Now, does this have a lot of implications on patient care? No, it doesn't. But we can see other scenarios where this will impact patient care. Here's an example where we have moved into the proximal portion of a tip stent. Take a few minutes to look at this image and decide if this is properly angle corrected. Again, this is not properly angle corrected, and there are a number of problems with this particular image. So first of all, we can see that our tip stent is oriented almost perpendicular to our angle of insonation. And we talked about the cosine of 90 being 0, and if we divide our velocity by 0, then we do not get a real number, and therefore we cannot measure velocities when we're perpendicular to movement. Okay? So we need a different angle of inclination here. In addition, the indicator showing how we've angle corrected for this case is clearly not aligned with the flow of blood. And so the velocity depicted here of 100 centimeters per second is misleading. It's inaccurate, and it has almost no meaning. So we really shouldn't be recording an image like this. We should not provide a velocity on the screen or try and improve our technique so that we don't mislead a resident on call, another clinician reading this on their own, or a busy attending moving through ultrasounds quickly. And again, the yellow arrow indicates that flow of blood that's 90 degrees to our angle of inclination. And so we aren't angle correcting properly, and our angle of inclination is not adequate to be able to measure blood flow accurately. So how does this measured angle affect our velocity? Is it an overestimate or an underestimate? So in this instance, we are underestimating our flow, right? We are under angle correcting. The true angle of inclination is 90 degrees. We're angle correcting to 60 degrees, okay? And so we are underestimating the velocity. The velocity within this portion of the stent is likely higher than 100 centimeters per second. I will tell you that this is the same patient in the same part of the tip stent, and the ultrasonographer has returned to the patient and is now re-evaluating the tip stent with a different angle of inclination. Is this angle properly corrected? Yes, this angle looks nicely corrected, right? We see that there's nice uniform flow here, okay, as opposed to on the last case where we saw aliasing, so they probably brought their color scale up to an appropriate range. And we see the flow of blood corresponding nicely to the indicator of our angle correction. And so this is probably a very accurate measurement, okay? And so we can see that we're now at about 140 centimeters per second in this location, which is well within our normal range and was similar to the prior study. This is just comparing these two images taken on the same patient the same day. So we see a 90-degree angle of inclination, we see apparent aliasing within the tip stent, we see velocities that are more than 40 centimeters per second decreased compared to the prior study. When the color scale is increased, there's no aliasing. With proper angle correction, we see velocities in line with what our prior studies would lead us to expect. Here's another case. I want you to take a look at this image and decide whether this is properly angle corrected. So again, this is improper angle correction. In this case, we see color flow that appears to be aliasing in the distal tips. It almost looks like an area of stenosis. And then we have a velocity provided to us that's 230 centimeters per second, which is going to lead us to conclude in this study that the patient has tip stent dysfunction. But really this angle isn't correct and our velocity isn't correct, right? The flow within this stent is more in the direction of that yellow line. We have a much more acute or smaller angle of inclination. So, how does this angle correction affect our velocity? Is this velocity of 229 centimeters per second an overestimate or an underestimate? It is an overestimate of velocity. So in this particular person, we now have aliasing, we have what looks like narrowing of the color Doppler signal, and we have a velocity over 230 centimeters per second. So we're probably, if we're not looking at this with a careful eye and doing good quality assessment or assurance of every study, we may be calling this study TIPS dysfunction, which would lead the person to having a venogram, meaning they're going to get a stick in their jugular vein, they're going to have some large bore catheters placed down into their liver, and they're going to be injected with contrast, which doesn't put the patient at great risk, but certainly increases their risks of complication and would have been an unnecessary study. So let's look at this and decide whether it is properly angle corrected. So this is a difficult spot, but I think that this is properly angle corrected. We can see that the color scale is properly aligned with the range of blood flow that we're seeing within the tip stent. We can see at the location of our spectral gate that our angle correction is relatively well aligned with the wall of the blood vessel and with our expected direction of flow. And here we have a velocity of 108 centimeters per second. I'll tell you that this is the same patient that we saw on the last case. So in this last case, where we see apparent narrowing, aliasing, and elevated velocities, we now come back to the same patient on the same day, and we see nice uniform blood flow with velocities that were within the range of the prior study and are within the range of normal. So again, this patient can avoid having an invasive and unnecessary procedure when proper ultrasound technique is used. So, improper angle correction can be misleading, and it often is misleading. A lot of our numbers have inaccurate angle correction behind them and are reported just as they are recorded on the ultrasound image. And that is currently affecting some of the research that's being done in the interventional radiology department, and hopefully we can improve our angle correction to make our tip stent dysfunction evaluations more clinically useful. At worst, an angle correction can harm patients, right? And we talked about how they could have to undergo an invasive procedure that may require sedation and requires intravascular access. So, if you cannot get your angle of inclination to be between 30 and 60, for some people between 45 and 60, that's okay. I want you to get it between 30 and 60, but if you can't, correct it to whatever you think the blood flow is. If you come in with an angle of inclination of 70 and an angle correction of 70, I'm going to be much happier than if you come in with an angle of inclination of 70 and an angle corrected to 60, because that disparity between the actual angle of inclination and the correction of the angle can result in mistakes. So in summary, accurately correct that angle, no matter what the angle you can get. Try and get the best angle you can, but whatever angle is the best you can do, correct it accurately. Thoroughly look at that distal tips. It's hard to see. This is the hardest study that we routinely do in our ultrasound department. There's no question about it. The patients are hard to deal with in terms of positioning. Their livers can be echogenic and coarse. It's a very, very challenging study. There is no doubt. And I think that our ultrasonographers have the ability to get excellent studies. I see very good studies from people, but I also see studies that haven't been properly performed. And so I want us to really work on improving the consistency and the quality of our studies so that we can help these patients, help the hepatologists, and help our interventional radiologists. A final point, certainly not as important as the other 2 points, is remember to adjust your color scale throughout the exam. Okay, I know it's a little bit of an extra step, it's a pain, but if we really want to be detecting aliasing, we are going to have to crank up that scale to get it within a proper range of the actual flow going through the vessel. Now, if you have it cranked up and you're not detecting flow, certainly bring it down, bring it down, bring it down. But that color scale in the appropriate range is more important than you might think. So, I hope after this e-learning module, you now understand how angle correction impacts the calculated velocities that we achieve with Doppler ultrasound. You understand that the distal part of the tip stent and how the tips is placed impact where dysfunction occurs and why we get the different measurements in the different locations that we get during the study. And I hope that you could look at any angle corrected velocity taken with Doppler and quality assure that measurement to make sure it is accurate and reflective of the actual blood flow within the vessel. Thank you for your time. I hope you found this educational and informative, and I will be developing a cheat sheet or handout that will go with it that can be used as a quick reference for performing TIPS ultrasound.